Namaste everyone. At the very outset, I'd like to thank you very much for your overwhelming response to the pre-course module and the lecture and your very encouraging participation in the Viva discussion. Your encouragement and your active participation is the source of inspiration for this pre-course module. Yet another lecture in the series of pre-course module is the value of pivot shift test in the knee instability. I am Dr. Amit Joshi and my moderators are Dr. Ishwar Pradhan and Dr. Rajiv Raj Manandar. There are more than 50 tests described for anterior cruciate ligament injury, but the most important of them are anterior drawer test, Lockman test, and the pivot shift test. Anterior drawer test and the Lachman test indicates ACL tear, but the importance of the pivot shift test is that it indicates the instability. So that is why pivot shift test is called the test for instability rather than the translation. That is why it is also known as the dynamic test. Here I am trying to demonstrate you how to do a pivot shift test. Put your hand underneath the sole so that you can internally rotate, keep in neutral position and externally rotate the leg. Then you flex the hip and abduct for about 10 to 15 degree. Put your another hand just beneath the fibular head so that you can give a valgus stress, and use your right hand while giving valgus stress by the left hand to flex the knee and the hip. And here you have to see two things. One, you have to see the abnormal movement of the tibia, and the another one with your left hand you have to feel any movement of the tibia into the femur. So here I am trying to demonstrate a positive pivot shift test. You can see that in about 35 to 40 degree of flexion there is a gentle glide of tibia. That means from the dislocated position the tibia is getting reduced, and you can see that the prominent IT band also moves and it pulls the tibia into its reduced position. There are basically two main components of the pivot shift test. These are translation, in which there is an anterior subluxation of the tibia, to be very specific, anterior subluxation of the lateral tibial plateau, and rotation. That means there is a internal rotation of the tibia relative to the femur. So a pivot shift test can be used to assess the combined tibio-femoral internal rotation as well as anterior translation. Pivot shift test may be falsely negative if there is MCL deficient and it is not possible to give a valgus stress. It may be false negative if there is a huge hemarthrosis and the knee is very painful. It is also said to be false negative if the patient is symptomatic osteoarthritic, either medial or lateral, or both medial and lateral compartments are involved with osteoarthritis. In these cases, the pivot shift test may be negative. In 1990, Matsumoto published in JBJS the mechanism of the pivot shift test. And in this mechanism, they have emphasized on three factors. One is the posterior inclination of the tibial plateau. The another one is the intactness of the medial collateral ligament. And the third one is the intactness of the IT band. So this IT band acts as the reducing force. So whenever there is a ACL tear and the leg is internally rotated, the IT band is anterior to the axis of rotation. That is why it doesn't work as a reducing force. When we gradually flex the knee and it goes about 20 to 40 degree of flexion, then the IT band comes posterior to the center of axis of rotation, and thus it reduces the knee or reduces the tibia into the femur. So this mechanism of pivot shift test has revolutionized the concept and understanding of the pivot shift test. Jacobs in 1987 have classified and graded this pivot shift test into three grades. They have used the position of the leg and presence of pivot shift test to grade into all these three grades. According to the Jacobs, the pivot shift test, if the pivot shift test is positive in minimal internal rotation and it is negative in neutral and the lateral rotation, then it is called as grade 1. If the pivot shift test is positive in internal rotation as well as in neutral rotation, but it is negative in external rotation, then it is called as grade 2. Similarly, if the pivot shift test is positive in all three rotation, that means it is positive on the medial rotation, positive in the neutral, and it is positive in the lateral rotation, then it is called as grade 3. A more simpler description of this grade are if there is a glide reduction of the tibia into the femur, then it is called grade 1. If there is a clunk, then it is called grade 2, and if there is a jerk or the tibia reduces to the femur with a jerk, then they are called grade 3. As far as the value of all these tests, the anterior drawer test, Luckman test and the pivot shift test is concerned, the Latchman test for the detection of ACL tear is very sensitive. However, pivot shift test is more sensitive than the anterior test, and the sensitivity of anterior test is around 80% only. Having said that, Lachman test, though it is very sensitive, it detects only the anterior translation. But the pivot shift test, although it is less sensitive than the Lachman test, it detects the dynamic instability or the symptomatology of the patient. But still, even if it is less sensitive, it is given more importance than the Lachman test because of the various reasons. The first reason is that the pivot shift test is the strongest predictor of need for ACL reconstruction. So whenever we are in confusion to decide either the patient requires a ACL reconstruction or patient doesn't require an ACL reconstruction, pivot shift test can be used as a rescue or a deciding factor. If someone is having pivot shift test positive, then most likely these patients are going to require a surgery down the line. But if the pivot shift test is negative, then probably a conservative management may be a good option for the particular patient. The second point is that the pivot shift test is an important test following ACL reconstruction also, and it is found to be strongly correlated with the functional outcome. So after the ACL reconstruction, if there is a pivot shift test is still present, the functional outcomes are not very good and the patient still feels the feature of giving way. But if there are no pivot shift positive after the ACL reconstruction, patient feels much better and the functional outcome are better than in those who have pivot shift test positive. More interest was raised after the concept of anterolateral ligament. So in 2012, when Monaco described the value of anterolateral ligament, and they concluded that cutting anterolateral ligament increased anterior translation and internal rotation, and they said that the injury to LLL could be related to the positive pivot shift phenomenon. So when the pivot shift test is very strongly positive, either grade 2 or grade 3, most of the time the anterolateral ligament are also torn. That is why they suggested probably this ligament has also to be reconstructed. So as of now, there are two indications for anterolateral ligament reconstruction. If the pivot shift test is grade 3, then probably the ALL reconstruction is required, or if there is a residual rotational instability after anatomic ACLR, most likely this patient will require some additional procedure on the anterolateral surface, probably the anterolateral ligament reconstruction. If you see this case, uh, this is examination under anesthesia just before starting the ACL reconstruction. There is grade 1 pivot shift test present in this particular patient. You can feel a glide, a gentle glide, a reduction of the tibia into the femur. And this is the case, same case after the ACL reconstruction. The hand doesn't feel any obstruction or any abnormal movement of the tibia. So even the grade 1 pivot shift test has been disappeared in this case. So to conclude my presentation and emphasize the value of pivot shift test, I'd like to conclude by saying that the pivot shift test is a predictor of need for surgery. So if someone who comes to you with a chronic instability, and if there is a pivot shift test positive, most likely this patient is going to need a surgery, ACL reconstruction, somewhere down the line. But if you feel that pivot shift test is not positive, and if the patient wants to change his activity level, then probably we can still think about managing him conservatively. Pivot shift test is also a very strong indicator of post-operative outcome. So after the surgery, if there is a still presence of pivot shift test, most likely this patient will require a revision. He will feel the giving way and the instability of the knee even after ACL reconstruction. High degree of pivot shift test grade 2 or more are used as an indication for ALL tear, and they suggested a ALL reconstruction. Post-operative pivot shift test can be used to determine the need of ALL reconstruction. Suppose a patient is having borderline 2 to 3 pivot shift test positive, and we don't know either the patient requires ALL reconstruction or not. So in these cases, first we can reconstruct the ACL and again see the pivot shift test. If it is positive, probably he'll require the ALL reconstruction also. If it is negative, he's not going to need a ALL reconstruction. So with this, I'd like to thank you all for your patience listening. Looking forward to see you all in 28 and 29 July for second BNB knee course, and also like to request you to give your opinion and follow very closely the Viva discussion of all the pre-course module. Thank you very much. See you next time.